Hello, everyone. I hope you guys are having a great Friday. We're going to try this again. Unfortunately, because of some internet connection problems, we lost Dr. Marzban. I am Dr. Kaveh Elahiun, your host. We are interviewing Dr. Peiman Marzban, who is a cardiologist in Winnipeg, Manitoba, Canada. He is a cardiologist practicing in Cardio one of the top cardiologists as per some of the websites I have seen. And hopefully, I'm waiting to see if I can invite him in and see if he can join us again, if possible. So we are hoping that we can get into some details with Dr. Marzban in regards to, health and cardiovascular health and cardiovascular disease, what we can do to prevent and what we can help basically with when it comes to cardiovascular health. So we are just waiting for Dr. Marzban. Details with Dr. Perfect. I'm so sorry,
No
Dr.
worries.
Marzban. We have some thunderstorm, and by the sound
Yeah,
of
we
it,
have.
it seems
Yeah,
like
we have our Wi-Fi is also disconnecting on and off.
our Wi-Fi was definitely problematic. I'm sorry again.
No worries.
Again, everybody. This is Dr. Peiman Marzban. We are extremely happy to have him in our program. He is a very, very busy man, and for him to carve out this time to sit and talk with us, we are extremely grateful for it. Dr. Marzban is
It is my
a
pleasure.
cardiologist, and he's a fellow of the American Academy of the Cardiology and also a master of American Academy of Cardiology. So we have one of the top-notch cardiologists with us, which is extremely something to be very happy about. Anyhow, in some of the websites that I was looking at, he's even rated one of the top cardiologists, which is fantastic. Anyway, as we were discussing, Dr. Marzban, we were talking about the most common cardiovascular disease that you come across in your office. Please, I'm sorry we got disconnected. Can you go ahead and repeat what you had said again? I'm so sorry for that.
Absolutely no problem at all. Happens again. Happy to be with you again. Well, the most common appears to be still atherosclerosis, coronary artery disease, and then due to aging population, we are having surge in the other heart conditions like heart failure, uh, different forms. We have two general different forms of heart failure, and also heart rhythm abnormalities like atrial fibrillation. These are becoming more and more prevalent nowadays with the aging population, and also valvular heart disease, of course, age-related valvular heart disease. We are past the era of having more rheumatic heart disease in youth and teenagers. We were able to prevent from rheumatic heart disease very efficiently, and now we're dealing with age-related valvular disease more.
And you just have been, I know you just moved your practice. Please tell us some more about what you guys do at Cardio One. We are extremely lucky to have such a leading technology clinic in our community. Please tell us a bit more about what you guys do at Cardio One.
Yes, well, Winnipeg was the largest city in entire Canada with no dedicated cardiology in outpatient setting. That was basically something I was missing for a long time, and I was thinking about it until we came up with an opportunity to open up this clinic with the help of a few friends. Uh, Here we are having a range of basically specialties operating. We have a walk-in clinic, small size, not 24/7, but in cases somehow they have missed or they have issues, they want to be seen, uh, we can fit them in. Then we have cardiac side, which is me and two of my internal medicine colleagues who are interested in cardiology. They have joined us and taking care of some of the patients we're receiving. And also we have endocrinology. We have three endocrinologists here in the clinic, which is very fortunate for us because diabetes is one of the most common association with cardiovascular disease. So we need them really to manage side by side cardiometabolic aspect of disease. We have just hired a pharmacist who is uh, very capable of counseling patients for smoking cessation, COPD, puffers, and weight management, nutrition guide. Very fortunate to have her with us. And we have hired a heart failure specialist nurse practitioner who's been uh, working full time in St. Boniface Hospital heart failure clinic, and she just retired from her full time job in St. Boniface. But uh, we were very fortunate to have her here part time, at least to help us to manage some of our heart failure clinic. In the near future, we're going to be having case managers and nurses for atrial fibrillation, atherosclerosis, peripheral vascular disease. We do ABIs for screening of peripheral vascular disease. We have echocardiograms, which unfortunately has a lot of criticism because of the wait time. Um, Here in Manitoba, at least we have some bedside machine to get a basic understanding of what's going on, to not to postpone the treatment when we really need it. We also have stress test machines, and also we have a 24-hour ambulatory machine facility, which we have 7 or 8 of those, which is much needed. We're looking forward to have a few more other tests available soon. Hopefully, it is just 9 months we opened up, and I guess we had a pretty successful few months, and we're just improving and getting bigger and bigger.
Fantastic. I hope everybody listened to this. This is a leading edge clinic, especially when it comes to cardiovascular health and endocrinology. Obviously, we are very honored to have such a clinic in our city, and with such a leading edge technology, which is offered, and you don't have to go to a hospital, it's in the clinic. So, Dr. Marzban, please, if you could, in some detail, explain some of the symptoms and some of the conditions that patients complain, which leads to further investigation, basically in cardiovascular and cardiac area for you guys.
Well, there's always a wide range of symptoms depending on what is the root cause of it. Most common uh, disease we were seeing is atherosclerosis, coronary artery disease. In the beginning, most patients feel shortness of breath, discomfort, pressure in the middle of their chest and or upper part of their abdomen while doing physical exertion. Normally starts with more than what ordinary physical activity is, and then gradually becomes more and more in a way that they feel discomfort in less than what used to happen before, and the duration of pain, for example, from 3-4 minutes increases to 10-15 minutes, and more frequent. Hopefully, the patient will, at least become convinced that there's something wrong and seek medical attention. This is something as kind of outpatient chronic presentation. Some people first presentation is acute, like with acute onset of substernal chest discomfort. That patient normally should go to emergency to figure out whether it's the cardiac or not. Uh, the other complaint we're seeing a lot is faint spells or coming close to faint, which could be really serious cardiac background on it, needs to be investigated. Palpitation rate, heart racing, dizziness. Uh, these are the most common symptoms we're seeing. Of course, it's important for patients to notice these symptoms and seek attention. Also, fluid retention, swelling, that's another thing which sometimes we see people just don't pay enough attention.
Well, I'm sure you see in your practice that everybody comes and says, I did a lot of work and I was really out of breath, and they
Yep.
basically say that I maybe exerted myself, and they don't really pay attention to it, and it becomes something bigger. So, what piece of advice would you say if I come to you and I say, you know what, I exerted myself, I was out of breath? What would you say that I need to do?
Well, of course, it depends on the onset and how long this has been going on, whether we have time to set up, let's say, stress tests, non-invasive screenings and tests. In some cases, is it in a way I directly send them to emergency, or we directly send patients for coronary angiogram. It depends on patient age, risk factor profile. If, let's say, someone at age, a male at 65, diabetic, smoker, high cholesterol, comes and tells me my chest is burning when I'm walking, I don't think I'm going to waste time to go for non-invasive testing and stress testing. I would directly send them for angiogram. Basically, normally, investigation starts with a good physical exam, good history, having a quick screening bedside echo to rule out unusual conditions, and then we start with the stress test. In some cases, we get to the diagnosis with simple stress test, which is always the best way to do it and cheaper and easiest. And then if we couldn't do it, then we proceed to imaging studies. That imaging study could be a nuclear imaging study, which normally takes 2 to 4 months to get it done. We can proceed to CT angiogram as well if we need more definitive answer. And these are the variety of tests based on the clinical presentation and risk factor profile, basically pre-test probability of disease. We basically plan to go ahead.
Perfect. And just to recap, we are extremely happy to have Dr. Peiman Marzban, who's a cardiologist at Cardio One, at Facebook Live today. He has taken the time from his busy schedule, and we thank him for that. We are discussing cardiovascular disease and cardiovascular health. Dr. Marzban, you mentioned something about diabetes and having correlations to cardiovascular disease. Could you please explain a bit more, maybe in a little bit of a detail, that how are they correlated?
Uh, well, they are both correlated in a different ways. For example, if you look at patients who have coronary disease, never had diabetes in the past, and we diagnose them with heart failure or coronary disease, if you follow them for years, you will see more than 60-70% of them, based on different numbers and studies we have, they become diabetic, or they have sort of glycemic issues with impaired fasting glucose and so on and so forth. Uh, Glucose intolerance and glucose metabolism abnormality goes basically hand in hand in heart disease. The opposite side is patient who has been known to have diabetes. They are at high risk of developing cardiovascular disease. Unlike most people believe that most common cardiac presentation of a diabetic patient is heart attack, it is not. It is heart failure. Heart failure is the most common, and patients usually start to feel short of breath, swelling, and those are the symptoms diabetic patients need to pay attention and seek medical help. And of course, then coronary disease, peripheral vascular disease, renal dysfunction, or chronic kidney disease. These are different way of vascular presentation and vascular complication of a diabetic patient. So either patients with heart disease or with diabetes, patients with heart disease, they may become diabetic. Patients who are diabetic, they have higher risk of getting heart disease.
Perfect. Now, I know you have been involved in some of the research. Would you be able to go into a bit of a detail and giving us some nibbles on it and letting us
Sure.
know?
Yeah, well, research and community basically based registries and observations. This is what I've been doing from the beginning. The first thing which I did actually was a little look at some of the snapshots of emergency presentations and small reports coming from Ontario and then from Manitoba with regards to a condition they called atrial fibrillation, which is irregularity in the heartbeat, which puts patients at significant risk of a stroke, and we have fantastic tools to prevent it. The difficulty was care gap. So either patients didn't know they have AFib, or once we diagnosed in emergency or family physician office, they didn't know what to do with it. And there was a lot of strokes in between, which we could see, and unfortunately, a bunch of them devastating, which could have been easily prevented. So that was the first thing, got my mind busy with it, and I was able to open up AFib Clinic in 2015. We hired another nurse. I tried my best to educate them as much as we can, and close to 2,000 patients we were able to see in that time frame. First year we saw 670 patients the first year we started, and then basically most of those patients went back to their family doctor, and in the second emergency visits, whatever, we taught the community how to deal with this and how urgent is the situation. We were able to see them within an average of 1 to 2 weeks from their presentation to emergency, since the time of a stroke and cardiac serious complication of atrial fibrillation could be within a few weeks or months. So they don't have too much time to waste here. And unfortunately, we were missing a lot of those patients, and we were failing them as a society, as a community. So that was the first thing I did. We reported our data. Actually, recently my nurse presented our data, latest data, after we wrapped up that clinic and moved to Cardio One, to Canadian Heart Rhythm Society, which they had conference last weekend in Montreal. It was very well received experience we had, which is basically native here. We did it ourselves in the clinic with the help of friends in the Winnipeg clinic, and now we are trying to learn our lessons from that model and do the same thing, same care for the other serious heart conditions in the Cardio One setting. So there are other randomized trials we're doing. At this point, I'm involved in 6 clinical trials with different fields. One of them is the Zatoa study. Actually, I'm one of the most active sites in the entire world, probably, in terms of the size of practice and the number of patients enrolled. This trial is a continuation of a COMPASS trial, which was intensification of anticoagulation in patients with chronic coronary disease, which with this combination, there was significant reduction risk of stroke, especially, and also cardiac events and mortality. Now we're doing it in the community setting to see what actually happens in the real practice. So clinical trials are something highly selected, very well monitored, very strict inclusion and exclusion criteria might not represent what you're seeing in actual community. So we always need these kind of studies after clinical trial to see how compatible are those findings in the real world practice setting. The other one I have is the brain AF, which is atrial fibrillation in group of patients which are borderline at risk of stroke. Basically, they are on gray zone. We don't know whether they are at risk of cardioembolic events. Some of them might develop memory issues with the smaller strokes, which we miss. We were thinking is because it's not a major stroke, then we don't need blood thinner or anticoagulation. So we're enrolling them, randomizing to different treatments to see who does better. With the cholesterol, we have studies. One of them is kind of watching ourselves as a community practitioners, how many of patients are getting to the target, and what are the actions as physicians we're taking in order to get to that target, whether we can improve in some aspects of our own practice or not. Several studies, and most of them are worldwide, multi-central, basically double-blind, randomized.
Well, I hope everybody realizes in Winnipeg we're so lucky to have such a clinic that world-leading research is being done on it, and basically the technology that we have here, it's probably one of the best that you can hope for. Now, Dr. Marzban, you went over the signs and the symptoms of cardiovascular disease. Please tell me, what kind of a lifestyle changes one will need to do to fundamentally, hopefully, either reverse or maybe stop their cardiovascular or cardiac condition from getting worse, basically?
Well, that's $1 million question, Kobe. I wish I had easy answer to it, but we're always recommending exercising. Canadian Cardiovascular Society recommends 115 minutes per week active activity and good intensity activity like brisk walking and running and exercising. Um, is everybody capable of doing it? Of course not. It depends on age and, of course, different comorbidities. Uh, One of the big problems we are seeing in the current community is the load of carbohydrates available in the community, and people's uh, basically tendency to use those carbohydrate uh, uh, loaded, sugar-loaded drinks and food and bread. So food basically is one of the biggest things we have to always remind people. Generally, cardiovascular research are relatively consistent that non-protein calories are the culprit for metabolic disease. And if you look at the percentage of calories used, you will end up in carbs, mostly carbs in Canadian diet. Sodium load is a big issue in some instances like canned food, bread. We have some brands basically we have lots of sodium in it, and some people they just don't read the label, or even if they read, they don't understand the implication. And despite having high blood pressure and heart failure, they just load their body with sodium. So it's always good to have a counseling with patients and going through exact ingredients they're using and remind them which part of it should be changed or not. The other thing which I'm seeing a lot here, people don't drink free water. They just drink a lot of other drinks, sweets and tasty drinks. Kind of a lot of people they used to have taste in their mouth once they're eating or drinking things, and they forget that the basic drink for human being is water. And I have to always remind them, make sure you're drinking this amount of water. Of course, in heart failure cases, we should limit the liquid intake, but those are not uh, uh, basically that common. Most people, they come with faint spell and dizzy spell, and we can't find anything. We end up seeing today, actually, I had a patient over the last 30 years, he never had a glass of water. All he drinks is pop and coffee. So now he was wondering why he's dizzy. So so
Well,
uh, so yeah, we see these kind of scenarios which sometimes you wonder what's going on, why we forget even basic things that despite having 25% of fresh water uh, uh, reserves in Canada, our own people, Canadians, don't drink free water.
that's true. True.
Right? So these are the basically, I mean, recommendations we come up in most cases of patients. Of course, we always recommend these changes happen early in the life. For someone who is 300 pounds at age 60, probably bariatric surgery would be a better option as opposed to, I don't expect that patient would be that much successful in weight loss and exercising because already they have arthritis in their legs, hips already replaced. Uh, I don't believe they're going to be able to do enough on the treadmill or any gym to get off that weight. In some cases, we need rapid weight loss and efficient, and that's the bariatric surgery.
Perfect. So just to put them all together, you're recommending, or at least it's physical activity is recommended per week. And how many hours did you say?
150 minutes
150 minutes per day, per week,
per week.
and more calories from protein rather than non-protein based, which so basically carbohydrates, all the sugars and all the goodies that we all like is basically out. And what's the genetic component into this? Is there genetics plays a component into cardiovascular disease?
Well, absolutely, 100%. Um, One thing that again I'm seeing a lot is being misunderstood or misinterpreted. A lot of people they come who had coronary event at age 50 or 48, and when they look at their LDL is 5.5 or 6. I had a 37-year-old guy just a few days ago. His LDL was 8, and he was super skinny. And I can show you a guy who is 300 pounds heavier than me, and his cholesterol is quarter of mine. So the fact that someone is skinny doesn't mean there are no risk. And I've seen a lot of family doctors. They say, "Oh, you're in good shape. You just, work harder or whatever." Uh, uh, Part of that, most of the basically LDL component in our body is genetic. So a cardiovascular risk assessment is always necessary, especially in male older than 40, female older than 50, if they have no other risk factors. If they have a family history, if they smoke, if they have high blood pressure, diabetes, it should have been done earlier, in younger age. Do a cardiovascular risk assessment, make a plan for future. We have different scoring system now, becomes available on computers, on apps, and you can come very close basically to who is at significant risk of cardiac events in the future, and be proactive. Actually, I just came back a couple of weeks ago from European Cardiovascular Society in Paris, and there was another study again published that if we look at the lower percentile of blood pressure, let's say people are 105, 110 kind of blood pressure, and genetically they have lower cholesterol as opposed to average. Let's say average Canadian is 3.5, their LDL is 1.8, 1.5. When you follow those cohorts with different average population, you see a lot less cardiovascular event. So it means genetic is important. The risk modification should be started at younger age. You don't wait until cardiovascular disease is established and then think about lifestyle changes. Or that's why we encourage even to start encouraging active lifestyle for our children to watch out what they're eating, to be on their weight, to make sure they're exercising. At the same time, if someone happens to have a risk factor unrelated to modifiable risk factors, like genetic or becoming diabetic type 1, those are the things that, despite being healthy, looking healthy, shouldn't be ignored. Cardiovascular risk assessment is 100% necessary. Bunch of those events we were seeing in their 60s and 70s are preventable.
Perfect. I have a question here that one of our viewers wrote, and they're asking about the venous insufficiency. What's the protocol and what can be offered to improve an effectiveness of preventing swelling, basically edema on their extremities?
Well, that's kind of out of my scope of practice. Uh, but we see venous insufficiency and engorgement of veins uh, in heart failure patients, let's say, for example, or with some right side heart disease. Normally, uh, my first recommendation is compression stocking, of course. Compression stocking as a prevention, always. Even when I'm on my feet every day, actually today I have it on. I have my compression stocking. You don't need to have necessarily develop venous insufficiency before you seek attention. You can uh, start from beginning to prevent from happening. But some cases I know they have been referred to vascular surgeon. They've been referred to different practitioners to basically have surgical closure or foam injections. And of course, in some end stage cases, we see they have skin ulcers and related complications, which are very difficult to handle. But it's kind of out of cardiology practice. Mostly the vascular surgeons deal with this kind of problems.
Okay, so you hear that stress has a lot to do with the body, and it causes much of the diseases that we know today. What's your experience been with the stress, physical, mental, emotional?
Well, we have enough evidence. We have enough evidence to believe that stress can increase the incidence of acute events in chronic setting, whether it is causing plaque building up in the artery. There is no evidence for that, but we know stressful life and type A personality, they are having higher likelihood of getting to cardiac event, or someone is a pretty calm person but has a period of stressful uh, life and that they have risk factors. You see the event happens in that time frame. So we have some evidence to uh, uh, believe that the stress is contributing to acute events. We have recently been seeing a lot of condition, we call it stress-induced cardiomyopathy, which we also call it Takotsubo cardiomyopathy, basically for other stressful conditions like mental stress or uh, uh, many other stressors like post-surgical, we see heart muscle starts to show signs of damage. And actually, you see heart muscle in that part, acute phase, is not moving. And some people actually develop with chest pain, and actually they have EKG and signs of heart attack. When you do the angiogram, there's nothing. So there's, of course, when you inject inside the left ventricle, there's a special feature on that, which we know that's typical for a stress-induced cardiomyopathy. And now we are recognizing a lot milder form of this condition. So yes, definitely there is a strong contribution in cardiovascular events. Question is whether it contributes to build plaque chronically. That's something needs to be seen. But at this point, I haven't seen any evidence for it.
Perfect. So just basically put everything together is a healthy lifestyle, physical activity, be mindful of what you're eating, reduce your sodium intake, which obviously covers all the processed food, anything packaged, anything pre-made, cans, drink a lot of water, which obviously it is a simple thing to do, but apparently not everybody does it.
Yep.
And reduce stress. Stop smoking. Use of tobacco has been known to cause cardiovascular disease. And well, these are some great points that I'm sure all of us can use and help get ourselves better. Now, in years of practice that you have had, I'm sure you have seen some different stuff. Now, what's the best quote in your life that you go with, and you basically it's your motto?
Uh, uh, well, I always try to be happy. I always try to be positive. Always reminds me Omar Khayyam's poem, which is in Farsi. It would be saying, uh, enjoy and be happy in the moment you're living, because these moments are eventually your life. So that's what I'm trying to do for myself and my patient, to make them feel good, to make them feel happy, and try to give them as much as I can to enjoy whatever life they have left over, and to make sure they're living happily with their family.
And Dr. Marzban, please share with us what is the secret that you're one of the best like cardiologists for the
I don't know.
for all the doctors who are on board listening. What is one gem that you can share with us that has helped you to be so well liked and be so good at what you do?
Well, it is hard for me to say. I really don't know. But I found the attitude is a big thing, and I immediately make friendship with my patients when they walk into the door. So that would be the key. I don't make them feel I'm the doctor. You don't know anything. You listen to me. When something needs to be seriously done, I'm quite tough. There is no room for negotiation on that. But everything is friendly, and everything is in a way that we are in the same family. The more and the happier you live, the better it would be for me. Uh, and I would enjoy to see patients are following the instruction, getting to the results, and as I said, they live happily with a good quality of life. That's the goal, and I think patients realize that. So probably that's what it is. It's nothing that much complicated.
Now, with all the experience you have, if we say we take you back to the year you graduated, what would you tell your younger self? One advice. What would be the one advice you will give your younger self?
Uh, for myself,
Yeah.
I don't know. Really don't know. I would continue the same thing I'm doing. I think uh, I made my choices really wisely. I would probably say tell myself, don't stop exercising when you were 15 nights call in a month. Still find a way to be active. That's probably what I would do extra. Those years, yeah, I wasn't active enough, and uh, I was blaming on calls and was very tired those days. Those are the few years I didn't exercise, and if I go back, definitely I try best another way to find to be active.
Now, I just had another question. They were asking about physical activity.
Right.
What kind of a physical activity and how intense of a physical activity would one consider to be benefit to the cardiovascular health and the heart?
Um, I would say probably any physical activity would be better than nothing. But of course, for patients who have established heart disease, that's a different story. So when you have a patient with a valvular stenosis, you want to limit the physical exertion. Uh, uh, you don't want them to be competitive or lift extremely heavy weights. Uh, but it is different from people who want to live healthy and they have no established heart disease. Without established heart disease, I would say probably the best idea is to have a group fitness programs and mixture of resistance and cardios. For patients with established heart disease, there are some patients like hypertrophic cardiomyopathy patients. We encourage them to not to be competitively active, and they just listen to their body and do regular and moderately intense physical activity, not to go too intense. Valvular stenosis is something we don't like them to be uh, uh, active in strenuous physical exertion. Coronary disease, fully revascularized with fully saved heart muscle, there is no limitation. They can really do whatever they want. As much as those people normally they're elderly in their 60s and 70s. Anyways, they won't be playing hockey or participating in very strenuous exercises. Normally, we refer them to cardiac rehab program. With a trainer, they look at their weaknesses and areas they need to improve. Uh, Basically, we go case by case. In aneurysm, let's say, we don't recommend heavy lifting, ascending aortic aneurysm, that kind of, or patients we know they're at risk. Uh, but for general public, for prevention, I would say mixture of those strenuous, resistance and uh, dynamic cardio is always better than uh, uh, anyone on its own mixture. And also, there is no limitation cardiac wise unless we have a cardiac specifically diagnosed cardiac disease. And as I said, depending on the severity and type of disease, we come up with recommendations.
Perfect. Now, please uh, tell our audience if we want to get a hold of you or if we want to be referred to you, what's the process? Obviously, you need a referral from their general practitioners, correct?
Well, that's exactly that's the practice we're having here in the referral based. We have a cardio one forms in all the clinics available, and based on the urgency they need, they can mark as first available physician, urgent, semi-urgent, or if they want a specific physician, they can write the name of a specific physician, and that's basically what we recommend to do so. Uh, and for patients who are having issues and they are not quite sure it's cardiac or not, it's not emergency, they don't have immediate access to their family doctor, they can use our walk-in clinic site. And our family physicians will be more than happy to help them and go through cardiac tests and stuff. And if they find something, we are always here.
Now, Dr. Marzban, what's the address of Cardio One
It is 230 Osborne Street.
and the phone number?
204
Perfect. So that if anybody needs to, that's the phone number that you guys can get a hold of Cardio One. Again, you had said it at the top of the program. Could you please kindly list the services that you guys offer at Cardio One so our viewers will have second chance of hearing them?
Yeah, absolutely. Well, we have a website. The best thing is to look at the Cardio One website to be familiar with the whole clinic and team. Some of the services, as I said, there is just evolving. We're still working on it. But basically, we have cardiology, we have internal medicine, we have a walk-in side, we have 3 endocrinologists. We have a pharmacy, we have a stress test lab. Of course, EKG is basic for any cardiology clinic. We have ABI for screening peripheral vascular disease, which is very common in patients who have heart disease. Well, not very common, but is not uncommon. The other test we have is the bedside echocardiogram for someone who really needs to get it done quickly, or family doctors, they need to know as soon as possible and they can wait for the regular echoes wait time. We can have a screening, a quick look at potential problem and come up with a plan. The other services we have is the heart failure clinic, which we have heart failure nurse. We have also a pharmacist who is specialized in smoking cessation and COPD management, and she is very knowledgeable for puffers, and she can prescribe on her own and cut back or whatever. She can manipulate the dosage. She has the license to do that, and also is very helpful for weight management. Hopefully we can use her a little bit more for weight management, of course. We are working on getting also case managers for different areas like atrial fibrillation, atherosclerosis, again, optimization clinics like that.
Perfect. Now, a website for Cardio One is www.cardio1ca.com. .ca. So it's www.cardio1.ca. Well, Dr. Marzban, I am grateful for your time. I thank you for carving this time out of your very, very, very busy schedule to help the community at large and to come on our Facebook Live. Thank you, and I hope we have been a grain of help for anybody who has had any sort of concern. Again, Dr. Peiman Marzban, he's a cardiologist at Cardio One. If you guys need to get a hold of them, they have a website, www.cardio, number one, it's cardio1.ca. Thank you again. I wish you a happy weekend, and thank you for being with us. Our viewers, thank you so very much for spending time with us. I love and appreciate every one of you. Give us a like, give us a heart. It will keep us motivated for more programs and more interviews to come.
Thanks for having me. It was a pleasure with you and the viewers as well.
Thank you so very much. You take care.
Thank you. Thank you. You too. Bye.